Okie dokie. So, in AMP1, and so I don't know how many of you have been through AMP1 other than, of course, the ones who were hanging with me this summer, but we covered general senses as one of our last topics. General senses are like pain, pressure, temperature, and so on. This chapter is special senses, which is what you were taught in like elementary school, like sight, hearing, tasting, smelling, and so on. So that's what we're going to cover in this chapter. The majority of this chapter is vision. I think it's like 80 slides of vision. And so I judge how long we're going to lecture by how many slides there are. There's 135 slides in this PowerPoint. Sounds like a great time. Okay, and the majority of them are vision. So you're going to know a lot about your vision before we leave today. Thank goodness for that, but we will also touch on the other senses. So vision, taste, smell, hearing, and equilibrium. We also covered previously in 01 the cortex of the brain and the parts of the brain that handle these specific senses, and then their association areas. So you're going to see reference to that as well. So we have like the visual cortex, and then we have the visual association. So real quick, visual cortex is what allows us to see, but what is visual association?
To associate with images.
Have I seen it before? Do I recognize that face, or do I need to create a new memory? Okay? So it does make references as we go through this and for each sense, but you have a specific area of your brain that covers that, and then you have a separate area called the association. So we have the visual cortex, then we have the visual association cortex. So it's a part of the cortex that is just trying to figure out if you've seen it. We have the same for smell, okay? And equilibrium is your balance, and that's going to be handled in your ear. So we will do hearing and equilibrium together. Vision by itself, then these two together because they're associated, and then those two together. So that's how it's going to be divided up. So the majority of your special sensitivity, real quick. If this is all senses, what direction is this information traveling? Up. From peripheral nervous system to central nervous system. And the term we use for that moving up is afferent. When you look at diagrams, all of this information will be in blue. Blue indicates to you that this is a sensory type of device. So it's traveling afferently from our environment to our central nervous system so that we can process it. Okay? So with that being said, the majority of your special senses you're able to perceive them because you can see. Okay? So like you can see fire, you could also smell fire, but you can see it as well. Okay? We're going to talk about how all of those kind of come together. It mentions that just for vision, half of your cerebral cortex is involved in vision. We're going to come back and we're going to also talk about, as we get deeper into the cerebrum, which is the main portion of your brain, the limbic system, which is your emotion. So when you see something, it can make you mad or sad or happy and so on. So we're going to, like I mentioned, we're going to take this back into the brain. But cerebral cortex, when it says cortex, what are we referencing? The outer few millimeters of any organ is called the cortex. The middle of that organ is called the medulla. So like whenever you look at the renal cortex, that's the outer few millimeters of your kidney. And the renal medulla is the middle of your kidney. So these are terms that you should be able to apply to most organs. Okay? It also mentions that your eye is cushioned by some fat. And you have your orbit, which we know from 01 is made up of 7 bones. Accessories that help protect the eye: eyebrows, eyelids, conjunctiva, lacrimal apparatus, and extrinsic eye muscle. We're going to go into each of these in detail, so I'm not going to discuss them at this moment. But here you have a really good looking eye up close. Some things to point out: of course, the first thing people notice in eyes are the color of the eye, and we're going to end up calling that the iris, which is the colored portion of the eye. Here is the pupil, and the pupil is not actually a structure. This is just an opening. So there's nothing behind the pupil. It's just an open space. And the size of the pupil is regulated by the muscle right behind the iris, which we'll end up calling the ciliary muscle. And it dilates and contracts in order to control the amount of light that is let into the eye. So the pupil is where light enters the eye. It'll go through there, okay? So that's actually, there's nothing there, just an open space. You, of course, have Your eyelids, your upper and lower or superior and inferior eyelids, which you and I will end up calling palpebrae, because that's their name. Okay, here, where they come together, we call commissures. So we have a lateral commissure, and we have a medial commissure. Medial means towards the middle, lateral means off to the side. We'll have our eyelashes. We'll also talk about our eyebrows and why those are important. And the white part of your eye, we call it the conjunctiva, but specifically, it's also the sclera. So you'll hear us say those names. And then the cornea is this transparent region that covers that. Other things here. Ooh, right here, what you and I call our tear duct is actually called your lacrimal caruncle. Why not just call it a tear duct? Because we have to sound really smart. Okay. When we talk about how tears are going to be released, which we will discuss, you have a gland right here that will release it, and it will wash towards the center here. And we'll discuss that physiology as well. So whenever you study anatomy and physiology, every chapter will start off with the anatomy, and then we'll go into how it functions. So what's the purpose of an eyebrow? Technically, the eyebrows are supposed to catch anything from falling into your eye. They're a protective mechanism. They catch sweat, and those of you who have been out here in this heat, a lot of times you'll have like a salty, granular deposit in your eyebrows, and that's just what they have saved from getting into your eye. For people who, for cosmetic purposes, shave your eyebrows, that stuff just comes straight into their eyes. So that's what they're there for. It also mentions that they serve as a little bit of shade from the sunlight. The purpose of an eyelid, and here's the first time it's referenced as a palpebrae. So the purpose of an eyelid is to protect your eye. So you have the superior and inferior palpebra, and then the line between them, because it's deep, we call it a fissure, and we learned those terms in 01. So the palpebral fissure is just what you call that open part where it's divided. Okay, so it mentions it's separated at the palpebral fissure. The eyelids come together at the commissures, medial and lateral, and then your little glandular aspect that's most medial, we call the lacrimal caruncle, which is what you guys always call your tear duct, like where all your sleep and eye boogers get stuck. Okay? Levator palpebrae superioris. This takes us back to our muscular chapter. Levator palpebrae superioris. Any idea what this could be or what it does? Yes, sir?
It lifts the eyelid.
It lifts the eyelid. Why can't we just say that? Again, we're doctors and we try to talk about around or above everyone's head. So levator means that it's going to elevate it. Palpebra is telling you that it's the eyelid, and superioris is telling you that it's on top. It's the one on top. Superior, and then oris for the eye. Okay? So it moves your eyelid up and down. You naturally blink reflexively every 3 to 7 seconds. As you age, you tend to blink less, and your eyes get drier, and we'll talk about that at the end when we talk about homeostatic imbalances. But the whole purpose of blinking also is to cleanse and keep any microbes from being on the surface of your eye. Keep that all nice and healthy. Continuing with the eyelids, you have eyelashes. And your eyelashes, for those of you who have ever pulled an eyelash out, if it's already loose, it doesn't really hurt. But if you pull it out, every single hair on your body has a nerve, so you feel it. And these function for sensory purposes, to let you know something's there. So if an eyelash gets in the way or something gets on an eyelash or it becomes infected and it swells, it's painful to you. Okay, it mentions that there are nerve endings there. Here it talks about the glands that are associated with lubricating the eyes. The tarsal or meibomian glands, which will allow for oily secretions. And then we have the ciliary glands, which are in between each of the hair follicles, and those are sweat secretions. So you have oil/water-ish. 2 types of secretions here. Okay, which is why you get a mixture of things. The eye boogers are dirt and oil, and then your normal tears are your sweat glands in between your eyelids. Okay, so that's why it's a conglomeration of those 2. And of course, if there's an infection, we'll get there. All right, a side view of the eye, and I really like this because it gives us a lot of good information. So you can clearly see the eyebrows up there at the top. Again, we've talked about their purpose. You have your superior and inferior palpebrae. Okay, so your eyelid, your palpebral fissure is that opening there. Then there's your levator muscle that's going to help lift that eyelid. Here, in white, is what we call the conjunctiva, okay? The conjunctiva is just that protective sac there, but we reference it based on its location. So you have the palpebral conjunctiva, okay, so where the palpebrae is, the bulbar conjunctiva, so that's around the bulbous part of your eye, and then you have the conjunctival sac, which is this area right here. The fact that we have that conjunctival sac also answers whether or not your contact can be at the back of your eye. It physically can't get there. Like nothing can get behind your eye. Okay, so when your contact gets lost in your eye, it's not by your brain. Like a lot of people are like, oh my gosh, it's all the way to the back of my eye. It's not. It can't physically get there. That conjunctival sac is going to stop it. So it might be deep in there, which is uncomfortable for you, but it's not by your brain. It didn't go to the back of your head. Okay, and of course this goes all the way around. This is just a cross section so that you can see it. Then you can also see here, this area here we call the sclera, and then here where it's transparent is the cornea, and you can see the iris, of course, and the pupil there as well. What else can we see here? You can see the fatty cushion, and you can see some bones associated with the orbit. What else is? I think I mentioned it. Any questions on the anatomy or anything that I can clarify? Yes, ma'am.
So if someone's eye comes out, that sac is big enough for it comes out as well?
Right. So
or is it ripped?
Right. It would have to be it would have to be torn. Mm-hmm. Yes, ma'am. Good question. Really good question. And of course that there would be some damaged tissue along with that as well. We're going to get into the internal anatomy of the eye. This is just the external. Additional questions or anything that I can clarify? Okay. The conjunctiva, which I was just mentioning, is that whitish type tissue. So it's a mucous membrane, and we studied in 01 that anything that associated with the environment or comes into contact with the environment is made up of what type of tissue? Epithelial tissue. So mucous membrane is epithelial tissue that has secretions on it that help for protective purposes. We talked about the palpebral conjunctiva, and I pointed that out, the bulbar conjunctiva, and then the conjunctival sac, and I mentioned that that's also where the contact lens rests. For those of you who are in here with me for the first time, a lot of times I teach with the pictures, and then the slides that follow have all the words to it. So you're getting it like twice right then. I'd much rather have a diagram to teach with than just a bunch of words on a slide. Okay. And the lacrimal apparatus. The lacrimal apparatus is what we reference as the lacrimal gland. That's this gland here, and it mentions its location in the orbit above the lateral end of the eye. So the lateral end of the eye would be on the outside. So on both sides, you have the lacrimal gland. And this is what we will end up calling an exocrine gland, because it has a specific duct, D-U-C-T, and we'll cover that again here in just a little while when we get to endocrine. But it has a specific duct for its secretions. The lacrimal secretions are your tears. So lacrimal secretion is nothing more than your tears. And what do your tears include? Water. They have different enzymes in them, okay? Antimicrobial agents, lysozymes. So, yeah. Lysozymes, anything lyso means that it's going to destroy it. Enzyme tells you that it's protein-based, so it's an enzyme. Antibodies, there's mucus there. When you blink, all of those tears spread towards the medial commissure. Do you remember where the medial commissure is? It's just a fancy way of saying right here on the edges. Okay? Here, I have my lacrimal gland. You can clearly see I have ducts. I have specific destination points for my tears. So we're not just releasing tears within our eye and then hoping that it makes its way out. It has a specific destination that tells it where it needs to go, and as you blink, those tears go across your eye and end up here. When you cry, people always ask, why does my nose run whenever I cry? Well, because you literally have a little empty tube here, and it goes right down. So as you're crying, the tears that are being overwhelmed are coming on the outside, which is what you see running down your face. But a lot of them, because it's overwhelming for your lacrimal caruncle, are coming down here and through your nose. So there is a reason. It's not just a random, oh, my nose runs when I cry. So does everybody's. Okay? Because those tears are coming down there as well. So you'll hear them, I'm not crying. But that's why. Okay? So that's the physiological aspect of how your tears roll. Questions on that or clarification? Okay? Extrinsic eye muscle. So if it's an extrinsic muscle, where's it located? On the outside of it. Your eye has 6 extrinsic muscles. 4 rectus and 2 oblique. What does rectus tell you? That they're straight, right? Or the fibers run parallel. So I have a superior rectus muscle. Guess where that is? On top, inferior, bottom, medial, middle, and lateral, outside. And then I have 2 oblique muscles that are going anywhere other than a 90-degree angle, so they have the curved type fibers, and they're helping to help my eye rotate. Okay, so 2 oblique muscles, and it mentions that, bless you, superior and inferior oblique muscles. So here's that. Rectus again means that they're straight. So your abdominis rectus muscles, those were muscles here that are straight. Okay, so rectus just tells us that those fibers are straight. So we have those 4 there, and then you have your oblique muscles. This is one of your oblique muscles, the inferior, and then you have the superior oblique muscle. And you can see for those, we learned another term when we talked about this humerus. At the end of it, there was a trochlea. Okay, and I said, here's the trochlea. It's going to articulate with the what? Anybody remember what the trochlea articulates with? It makes your elbow. I'm just going to tell you it's the ulna. Okay, so the trochlea, and I said there's going to be one other place where trochlea comes up. And there's no way to distinguish between them. If you just see the word trochlea, you're going to have to read what they're referencing. If they're referencing the eye, then they're talking about this structure here. If they're referencing the upper limb, they're talking about the articulation point between the humerus and the ulna. So there's some times where we put a name and we give distinguishing characteristics within that name that tell you this is what I'm talking about. This is one of those that is not set up like that. But this is the trochlea, also called the trochlea. And the trochlea is where that second oblique muscle, that superior oblique muscle, has to kind of hitch through so that it can help that eye move. Okay? So again, you have 6 extrinsic eye muscles, and they're all labeled here on this fancy diagram. Here's a different view. Oops, going back. Sorry. Okay. Each of these right here lists the eye muscles. This is just for reference. We're not going to go through it, but there's a lot of diagrams as you go through these notes. I meant tables. Here's the actual muscle itself. So we've discussed all the names. Here's specifically what it does for the eye, and that is the nerve that innervates it. So each of these are articulated by an oculomotor nerve. We learned in 01 that oculomotor means it's doing what? Moving the eye. Like, we're using terms that make you sound really smart, but if you can just take a minute to dissect it, it just means we're moving the eye. And guess what a muscle is responsible for doing? Moving. So an okay, got it. All right, anyway, so, and do you recall what the abducens does if it's abducting, abducting? What direction? Away from, right. Abduct goes away, adduct is bringing back. Okay, structures of the eyeball. So now we're done with the external anatomy of the eye. We're going to look at the specific eyeball itself. We're going to talk about what it looks like and all of its divisions. So there's 3 layers of the eyeball. Fibrous, which is going to be on the outside, vascular, which is going to be in the middle, and the neural layer or inner layer, which is going to be on the inside. Just to kind of put some terms with these to maybe familiarize you with them more, the inner layer is a lot of times what we call the retina. Okay, so this is all going to be yellow because it's nervous tissue. The vascular layer is going to be a brownish or reddish color because it has blood in it, which is why it's called vascular. When you dissect your eye, you'll see that. And the fibrous layer is going to be on the outside. It's connective tissue, so it's white and it's durable, and it doesn't really stretch and flex that much. So it's more of a protective component of that eye. When you see the term humors, humor is the term that we use for fluid in the eye. So vitreous humor, aqueous humor, that's just a fancy way of saying that's the fluid in that part of the eye. We'll talk about the lens. When you dissect your eye, not your eye, but the eye that you will be given, the lens is actually like a marble structure. So you'll be able to take it out and you'll hit it on the table and it makes this like little clanking sound. And we all have that. You're going to be dissecting B5s. So they're pretty big lenses there. And so that's what the lens does. But it divides the eye into its two parts. And then we have subparts, of course, because it wouldn't be anatomy if it was simple. All right. I'm going to give you a lot of information with this diagram. Of course, it's going to be followed up with the notes on the slides that follow. Right here. So here's my lens. This right here is what we reference as being avascular. Avascular means that there are no blood vessels that serve that tissue. So if you damage the lens, you can't fix it. Okay? It can only be surgically fixed or altered outside. Your body will not fix itself. This lens is our point of division in the eyeball. So here we have the posterior segment. Here we have the anterior segment of the eye. Again, anterior means front, posterior means back, so it should fall perfectly with it if you understand all the terminology. The posterior segment, and this is just for teaching purposes, this humor here fills the entire eye. This humor here is what we call vitreous humor. Vitreous humor is made embryonically. So you made this while you were developing inside your mom, and it is the same vitreous humor your entire life. If that part of your eye is damaged, you won't replace that vitreous humor because you made it embryonically. Okay? When you dissect your eye, you'll see that its consistency is like a warm jello. So it's got some chunkiness to it. It's not just like a liquid fluid, but you'll feel it. Of course, we have gloves, but you'll see what I'm talking about. So vitreous humor, it's what kind of gives the eye its shape internally, and it helps with that pressure, what we'll call intraocular pressure. Okay? This part of the eye also has a humor, but we call it aqueous humor. And this aqueous humor we're making constantly. Okay? So if you get something in your eye or there's something damaged there and it gets washed out, or it needs to get washed out, we're going to wash it out. In the event that these little openings right here, which are called sinuses, and most openings are going to be called sinuses or foramen if it has a nerve or a blood vessel, but sinus is just an opening. These sinuses are for draining that aqueous humor. In the event that that aqueous humor can't drain, all of it starts to build up and it causes pressure there, which can lead to glaucoma. Okay, so it increases intraocular pressure, it puts that pressure causes pain, distortion of vision, and all of that. So that's this. This is constantly, this right here makes that fluid and it washes out constantly. So we're making this. This has been there forever. The three layers of the eye. You have the fibrous layer here. This fibrous layer is our sclera. So it's sclera until it gets to right in front of the lens, and then we call it the cornea. Okay, so sclera / cornea. This is connective tissue, avascular. Right here is the choroid layer, and you can see that it's kind of a reddish-brownish color because it's the vascular layer. It has blood, so that kind of gives it that color. And then, as any nervous tissue would, be depicted in yellow. So here's my inner or neural layer. That's the retina. And there's going to be two parts to that, and we'll get there when we cover the details of the retina. Right here, this lens, this marble structure, has these what we call suspensory ligaments. These suspensory ligaments are attached to these ciliary bodies, and whenever this changes shape, it determines what you see. So if it stretches out, it allows you to see far, and if it condenses up and kind of chunks up, it allows you to see something really close. And we'll talk about that in accommodation. Here is the muscle that controls the color of your eye. So the iris, the colored part, is right here, but this is the muscle that controls that. So when this muscle dilates, it allows the pupil, this open space, to get bigger, and when it constricts, it gets smaller. And we're going to pair that with sympathetic and parasympathetic activation here in a moment. Right here is the blood supply. These are all the vessels that you can see in a living person. You can kind of see on their outside. This blood supply goes back to the brain. So this is your optic nerve. Goes back to the brain to send that information. But because the retina is not continuous here, this is what we call our blind spot. So this part right here is called the optic disc. The optic disc is our blind spot. The part of your eye where you see the best is right here. This is the macula luda, and in the middle of it is called the fovea centralis. I'm pretty sure it's all labeled. Yeah, there you go. And this is your best vision. And I think I've covered everything I can on this diagram. What questions do you have or clarification on just this? It's going to be followed up in the notes, but here is an actual eyeball with the same structures labeled, so you can look at that. The fibrous layer is divided into the sclera and the cornea. So sclera is the majority of it. The cornea is the part that's right in front of your lens. And it tells you that there. The middle pigmented layer is called the vascular layer, also referenced as the uvea. So if there's other names, they should be in the notes, and if the other names aren't in the notes, I'll tell you them so that you have them and know what to expect. But the uvea is also called the vascular layer. There are three parts to that. The choroid, which is the part that I pointed out around the eye, and I'll go back whenever there's another picture. The ciliary body is the part that makes that aqueous humor. And then the iris, which is the colored part of your eye. So, and it gives you that term, and it gives you details on it. I kind of explained it as I was showing it to you on that diagram, but here goes into a little bit more detail. Okay, the iris, I mentioned that it gets larger and smaller, which will change the size of that pupil space. Close vision and bright light. If you're trying to look at something really close or there's a really bright light, we should see your iris get smaller or get larger and your pupil get smaller. So when you're looking at something really close, or somebody does that light test and takes a flashlight and puts it in your eye, if you're not under the influence of anything, your very large pupil should get very small very quickly when somebody puts a bright light in your eye. In the event that you are in a really light situation where there's a lot of light, your pupils should be smaller because it's damaging. But if you get into a dark situation where the lights begin to get dimmer or it's more difficult for you to see, you should see your pupil get larger because it's trying to collect as much light as possible, and it's a part of your sympathetic or parasympathetic activation, depending on what it is that you're doing. If you're trying to look something far away, your pupil's going to get larger. If you're trying to look at something far away, something close, it'll small, far, it'll get larger. You also can tell when people are emotionally disturbed or upset or excited by the reaction of their pupils. So when you get into things like interrogation or things like that, you actually learn to read people's body language and the movement in their pupils, whether they're dilated or constricted. And you can tell those are things that they use to determine whether or not you're telling the truth or you're scared, if you're really thinking hard or something like that. So here's showing you. Do you recall what parasympathetic means? Slows us down. Parasympathetic is your rest and repose, and sympathetic is your fight or flight. So when you're resting, we would expect that there's not a lot going on, you're not very stimulated. Okay, so you might be reading, and that's the example it uses in your book, and if you're reading, it's close, so your pupils should be small. Sympathetically activated means fight or flight, and your pupil gets really large, or this area gets large, because this muscle contracts, it comes back. That allows for a lot of information to be taken in, so that, or visual processing to occur, so that you can determine what it is that you need to do. And it also tells us that you're scared, if you're scared. Okay? The inner layer, which is the neural layer, the retina, there's two parts to that. There's the pigmented layer. The pigmented layer is one cell thick. It's just one, and I'll show you when we get to the diagram, it's just one lining of cells. Then you have your actual neural layer, which has your photoreceptors. What are photoreceptors? light receptors. Those are your rods and cones. So a lot of times people are talking about, oh, rods or cones or whatever. We're going to get into all that. But cones see color, rods see shape. Cones color, rods shape. We also see bipolar cells here. Bipolar cells were brought up in the nervous chapter. They're only found in special senses. So this is, it said that in that chapter. It says you're only going to see these in special senses. And guess where we are right now? Special senses. So all of these are going to have bipolar cells. And do you recall what it means to be a ganglionic cell? This is a group of cell bodies. So a group of cell bodies all together. So it makes kind of like this little bulge to it. When we talk about the blind spot, I told you that was also called the optic disc. There's no photoreceptors there, so you can't see there. When we talk about the two types of photoreceptors, so photo tells us light, receptor tells us it's sensory, rods and cones. I'm a memorizer, so cones are color. If I can remember cones are color, then I'll remember that rods are everything else. So you see color because of your cones. Okay, you see shapes because of your rods. So, showing you all of this in a little bit more detail. Okay, so you have the sclera here, which is your outer layer. Then you have your vascular layer here, also called your uvea. Then, really, really small is that pigmented layer. And then here are your rods and cones. Here are your rods and cones. And we'll talk about that as we get a little bit closer. So here is just the neural layer, the inner layer. Here's my pigmented layer. It's literally 1 cell thick. And it says that in the description. So this is 1 cell. This is 1 cell. And they each have their own nucleus. So you can see that they're just 1 cell. And then here are my rods. And then these are my cones. Do you know why we call them rods or cones? Their shape. Literally, it's because of their shape, which is good. Because sometimes it's just not that clear. Okay, here are our bipolar cells. So bipolar cells are where the cell body is in the middle. So we can see that, again, only in special senses. And then we have ganglionic cells. And ganglia are where there's going to be bulges, a bunch of cell bodies. So the way light travels in will go in this direction. And then the way you process what you see comes here, back to this nerve, and then to your brain. And this all happens super fast, obviously, but that's exactly how it goes in. So the light comes here, and the information is then processed and goes to the brain. So anything yellow, again, is going to be nervous tissue, and that's going to be that optic nerve, takes it back to a brain. Questions or anything that I can clarify right now? Yes, ma'am.
Colorblindness.
Yeah, it means that you see different colors, but you're missing one for cones. So it's an issue with cones, and we actually cover that here in a couple slides. Additional questions or clarification? Okay, this is that same, but this is animated, obviously. And this is what it actually looks like. So just you can see in comparison to. Okay, so rods. Whenever I think of rods, I think of people who have contacts or glasses. And I can say that because for a long time I did. When you have contacts or glasses and you wake up in the middle of the night, at your house, you know where everything is, true or false. Like you could walk through your house, your eyes are closed, you can get to the bathroom and not hit a thing. But what about when you stay over at your friend's house or you're at a hotel and you don't have, the lights are off, okay? Even if you put your glasses on, you really can't see because it's dark. You don't have but you can tell there's a shape of something. That's what rods help you see. Rods, you might not know what it is, but you're like, there's a table there. Or, I don't know it, but there's something really tall right here. Or I can see that column before you walk into it. Rods are what help you see that. They don't help you see color at all. And there's not any type of sharp, defined image that they help you see. But they help you see the overall kind of shape of how it all comes together. Like a silhouette. And if you know what I'm talking about if you wear glasses or contacts, like you can tell something's there, but you don't know what it is. You're like, and you're like squinting really hard, trying to figure out, and it doesn't matter if you squint because you're not going to see it anyway. But that's what that is. So rods help you kind of see the overall shape, but no distinct characters or color to that. Okay? So rods. Cones help you see color. And you have different types of cones, which is because there's different wavelengths of color. And color blindness would be lacking one of those. Color blindness is X-linked, so you typically see color blindness occurring in males, but there are colorblind females. Yes, ma'am.
So squinting, like something people do to try to force the body to draw in more light to see better?
So people squint because it helps them focus. So if they look at something, they're trying to focus just on that and get out anything in their periphery.
Gotcha.
And so the problem with squinting is that it engages extraocular and intraocular muscles, and so it puts strain on them. And so it's usually followed up by a headache. And of course, if that's any of you guys, you either sit at the front or you wear your glasses, because, or at least hopefully at this point in your life you have decided that. But that's why you squint. You're trying to take away everything in their periphery and just focus on whatever it is that you're trying to see. I mentioned that the macula luda is the back of your eye, and the fovea centrale, because it's just cones, this is your best vision. Your best vision. And not that you're looking at something saying, "Ooh, I'm looking at this with my best vision," but it's naturally just incorporated into what you're seeing. So you probably, I mean, and if you do know, that's really cool, I guess. All right, so blood supply to your eye. Any questions on rods or cones? I didn't ask. Blood supply to your eye. So you have two things that supply blood. You have the choroid, which is the vascular layer, which is that reddish brownish color because it has blood. But then you also have those vessels, the blue and red, so oxygen rich and oxygen poor, that came through the optic nerve. So that's our central artery and vein of the retina. Those, I told you, you can see that. If the person is alive, you can see those vessels in that individual's eye. Why can't you see them whenever they're dead?
Because
There's no blood flow to that, yes. So it's just a glossy, like, well, not that I need to reenact that. You get what I'm saying. Here, these are some great pictures, and those of you who go to the eye doctor have probably, well, whether you've looked at it or you're, you know, you can. This is what they're looking for. And they're looking for, you can see where there's no, the retina's not continuous here, so this is my optic disc, this is where my optic nerve is going. We're also looking for any type of growth, like dark spots, because dark spots would tell us that there's damage in those certain areas, which might explain pain or loss of vision, tumors, and things like that. You can clearly see the vessels, and all of these vessels will collectively go back into the middle of that optic nerve and back to our brain. All right, the internal chambers and the fluids, and I mentioned this, but here it is all going to be in words. So your eye has the posterior segment and the anterior segment. That's where we're starting. The posterior segment is filled with vitreous humor, and that vitreous humor is made embryonically. Yep, forms in the embryo and it lasts your entire life. Okay, it's what gives your eye its holistic shape and helps to keep it that, because it's your eyes are hollow, but they're filled with that fluid in order to help give them their shape. The anterior segment, and this is where I said, you know, in anatomy we can't just keep it simple. The anterior segment, which is where the aqueous humor is further divided into the anterior and posterior chamber. Do you see where we went from segment to chamber? So make sure you keep those terms clear and distinct. Okay? The anterior chamber is defined as being between the cornea and the iris. So the cornea is the very outside, that clear part, and then the iris is the colored part. Okay? The posterior chamber is between the iris and the lens. So this is putting clear, distinct reference points so that you can tell exactly where this is located. It mentions that the anterior segment has the aqueous humor, and I mentioned that. That's the humor that you're making continuously. Okay, so it's recycled out every few hours. It supplies nutrients and oxygen mainly to the lens, because remember the lens is avascular. We still have to take care of it. It helps get rid of any waste. Glaucoma is whenever the drainage, those sinuses have been blocked, and so that fluid builds up and it creates a pressure that makes it really difficult for you to see. So increases pressure, causes compression of the retina, optic nerve, and eventually lead to blindness. Okay? So glaucoma is just that aqueous humor building up. So, same picture from earlier. We have our two segments. Posterior segment, anterior segment. The anterior segment is further divided into the anterior chamber, so that's between here and here, and the posterior chamber, which is here to here. Okay? Aqueous humor here, vitreous humor here. We have our three layers. The outer layer, which is the fibrous layer. This is the sclera and the cornea. Then you have the choroid, which is the vascular layer, also called the uvea. And then that is continuous with the ciliary body, and then the iris. Then you have the inner neural layer, which is made up of the pigmented layer, and then the retina, which has your rods and cones, bipolar cells, and ganglia. Vitreous humor, aqueous humor, and suspensory ligaments are what's holding the lens in place. I think we get to that next. I think, yes. Here, it's showing you the ciliary bodies that are producing the aqueous humor, and it's showing you the flow of that fluid and how it drains. So you're constantly washing out and collecting any debris in your eye. This is internal. This is not on the surface of your eye. That's all done by tears. That's external anatomy. This is internal. And it continues to do that. Again, vitreous humor is created at birth, and it stays your entire life. Questions here? Anterior chamber, posterior chamber. Anterior segment, posterior segment. Everybody good? Yes, the lens. Your lens is biconvex, which means it goes like this. Okay, biconvex. So your lens is shaped like that. It's transparent, it's flexible, and it's avascular. Avascular, A tells you it's lacking, and vascular tells you it's blood vessels. So it's lacking blood vessels. It changes shape because of these suspensory ligaments that allow you to accommodate and to focus on things. And we're going to talk about that in physiology. Yes, ma'am.
So when someone has a
Stigmatism.
yeah, is that affected in the lens area?
We are actually going to talk about that. But yeah, ish. It's actually the shape of your eye, but can be corrected by. So we're going to get there. Yes, ma'am. Cataracts are where your lens becomes clouded. A lot of reasons your lens can become clouded. It could be just because you're getting old. It could be that you have some type of chronic disease, and chronic tells us what? You've had it for a really long time, okay? Like you've had diabetes your whole life, or something like that. We also see that people who smoke a lot begin to develop cataracts. Not always, but it's definitely a risk factor. Frequent exposure to intense sunlight or welding. When people are looking at the light from welding and it damages their eyes over and over again, that's another thing that could lead to that. So cataracts are clouding of the lens, and we already mentioned what causes that. Also, once you have cataracts starting to form, vitamin C actually exacerbates that. So you're supposed to, be taking vitamin C in order to stay healthy. But if you're just taking vitamin C just because you're a young, healthy person and you're taking care of yourself because you take multivitamin because you're a good person, not that you'd be a bad person. Anyway, vitamin C will but right now, just being healthy, it doesn't cause you to develop cataracts later on in life. So I don't want you to think that, I'm never going to take vitamin C again. In the event that you do develop cataracts, you can have your lens surgically replaced. So they go in, they take your lens out, and they put another lens in. Where do they get the other lens? From an organ donor. They have to get it from a cadaver. So somebody who has expired already, they'll take it from them to be used. You can also have artificial lenses that right now the laser eye surgery and lens replacement are not the same thing. But with those tools, we can access that tissue, and we can help people who have cataracts and can't see get their vision back. So here is a close-up picture of an eye with cataracts, and they often reference this as like a starburst effect. So this would be that starburst where it just kind of goes out like that. this individual cannot, the light doesn't pass through the way it's supposed to, so sometimes, depending on where the light can pass through, people with cataracts can like see the top of something and the bottom of something, but they can't see the core of what it is that they're focusing on. And sometimes they just can't see it all. So it just really depends where the damage is and how far along it is. Questions on any of this? Yes, ma'am.
Well, this is kind of a random question, not necessarily this, but like, how does vitamin A like play into?
Okay, so vitamin A will help us with our rods and cones, but not with our cataracts. So vitamin A is going to help with the retinol and all of that, which will help us see color and keep our retina, but the retina and the lens are not going to be associated. So when you're talking about like night blindness and all of that, is that what you're talking about?
Yeah.
We're going to cover nyctalopia here in just a little bit, which is where you're night blind. And if you are just beginning to become night blind, vitamin A will help fix that tissue. But if you've been night blind for a long time and that damage has been done, vitamin A is not going to help. But vitamin A does help increase your vision at night if you're taking it early on before damage is done.
Do cataracts affect just the pupil or the iris as well?
It's not the pupil or the iris, it's the lens.
It's the lens.
It's the lens. It's the lens. So right now you can tell in this eye that the iris is here, but the pupil, like you can barely, because the lens is so damaged.
Okay.
So they're not seeing what they should be seeing. Good questions. Additional questions before I just click through and didn't ask? Okay. Here we have light, and it's going to explain actually how we see, the physiology of how we see. So we have our visible light spectrum, which for those of you who are straight out of high school, you learn this in physics. We have the light spectrum, which is 400 nanometers to 700 nanometers in wavelength, and that's your Roy G. Biv. So your red, yellow, orange, green, blue, indigo, and violet. When we talk about light, we don't talk about light like energy. We call it photons of light. So the grouping of the light would be a photon, how we would reference that. And how you determine what the color of an object is, this is a physics principle as well. The color of an object is whatever color it reflects. So if you have a red shirt, your shirt is red because it's reflecting red, but it's absorbing green, blue, all of that. If you have a white shirt, it's reflecting all the colors. And if you have a black shirt, it's absorbing all the colors. So all the colors are coming together. So what you see is what it reflects. When it says, why is the sky blue? It's because it reflects blue, and that's what you see. Like, that's really the answer to that question. Okay? Here's our visible light spectrum, so our Roy G. Biv, so red, orange, yellow, green, blue, indigo, and violet. Those are the colors that you can see. This is our visible light spectrum. You can see gamma rays, X-rays, UV rays. These are not visible to our eyes. Then infrared, micro, and radio waves, we also cannot see those. We just have that small little segment which we reference as the visible light spectrum. Okay? Shorter wavelengths are more powerful. Longer wavelengths, not so powerful. Okay, so they're short and compact and powerful, and longer, not so powerful. When we talk about refraction is where you're refracting light. So because your lens is not flat, it's curved, it's going to refract. So this is explained like this right here would be considered refraction. So we know that the straw is one solid piece, but because of the way that our eyes are shaped and the way that that water and that glass come together and it's curved, it appears that there is a straw broken in half right there where the water is. So that's refraction. Why do we have refraction? It's because our lens is curved. Again, our lens is biconvex. It's biconvex, so when light comes in, it goes to a focal point, but then when it hits the back of our lens, it scatters. So it goes in, and then it scatters. Okay? And I'm going to show you that. If you have a concave lens, so your lens is like this, the light would come in, it would focus, or the light would come in and would scatter, and it would scatter first, and then it would try to focus on one point. We wouldn't be able to see what we were supposed to see. So if we're going to talk about nearsighted and farsighted, some of you wear contacts that are concave so that you can focus the light correctly, is what I'm trying to say. And my son's calling at the same time. I'm sure he's fine. I hope he is. Okay, so this is what you should. This is how our lenses are shaped, and this is a concept that I'm going to tell you right now. I'm going to explain what's about to happen, but then the very bottom part, I'm going to tell you, for the life of me, still can't process it, and I've studied for hours and hours and hours, still can't process it. And if you can, don't tell me the answer right now, because it'll take a long time to explain to me, because I'll ask a lot of questions, but maybe at a different time. But you can see how it comes together, it brings everything together, and then it brings it to a focal point. Here, what you see is technically reversed and upside down. What? So my questions are, am I actually on the root? I can't comprehend that. And I think it's because I'm very analytical. But still, look at this. What? It just blows my mind. So this is just one of those things that I've just accepted. What we see is reversed and upside down. Okay. It's so confusing to me, but that's because I ask a lot of questions. And it's because of the shape of our eye, of course. Great. I still don't get it. Okay, so I just memorized it. So I can choose the right answer on the test, and I can tell you that that's what happens, but I can't understand in my head why that happens like that. I know, me too. Okay, how the light enters your eye, and I believe that this is a test question. It's either in hybrid or it's in long semester. But light enters your eye. It would go through your cornea, so this is like physically how light enters your eye. It goes through your cornea, then of course the aqueous humor, then it hits the lens, vitreous humor. It goes through the entire neural layer, which means all the rods and cones, all the way to the pigmented layer, the photoreceptors, and then it goes, that's how far the light goes, and then the message goes back to that optic nerve, and it sends it and tells us to go. Light is refracted 3 times. When it enters the cornea, it enters the lens, and it leaves the lens. So those are all 3 shaped in a curved situation. We want them to be curved because it allows for focusing. But what if they're not curved right? Then we focus differently. And that's what leads to eye problems, nearsighted, farsighted. And that also is our shape of our eye as well. So we're going to get into that here in a little bit. But this is what we would call an emmetropic eye. Emmetropic means a completely healthy eye, emmetropic. This is what we would expect to see. Focusing for distant vision. I told you when you're looking far away, then your pupil is going to be large, okay, because it's trying to let in a whole lot of light. And here's the term emmetropic. The distance beyond where no change occurs is the far point of vision. Your ciliary muscle is relaxed. That means that it's gotten bigger so that your pupil is larger. Okay? So you'll see a larger pupil if somebody's trying to focus something far away. Here is an emmetropic eye. You can see that the pupil is larger. Look at these suspensatory ligaments. They're pulled here. And these are things, in college when we have a diagram, it's to teach you something. In high school we use it as a distractor. I don't know why they do that. You should use them all for the same purpose, or else college students don't trust diagrams. But these ligaments right here are intentionally pulled tight to take that lens and stretch it. The pupil will be dilated. This is a sympathetic eye. I'm trying to gather a lot of information. You can clearly see also that my R is reversed and upside down. I still don't get it. Anyway, but that's what this is. This is emmetropic, a nice, perfectly round shaped eye. For distant vision, for close vision, I'm going to see the pupil do what? I'm going to see it constrict. I'm going to see it get smaller. My lens is going to go from being nice and flat and pulled to being kind of chunky. And the suspensatory ligaments are going to relax. We call this the accommodation of the lens. So it's just accommodating to a closer vision. My pupils are going to constrict, and my eyeballs are going to converge. What does that mean? Convergence of eyeballs. They're going to go, when you're trying to look at something up close, your eyeballs converge whenever you're looking at it up close. When you're looking far away, they don't diverge like they go to the sides, because that would be crazy. I mean, some people who have lazy eyes, they do that. But when you're trying to focus, you're going up for a long distance or far distance, and then you come together for close distance or close up accommodation. So accommodation, the term accommodation, I'm going to go right back. So when it says accommodation of lenses, this is your lens changing its shape. The accommodation of lens, the changing of shape of the lens. For a near point of vision, we want the lens to get flatter. Okay, I don't let me use flat because I used flat to explain how it's stretched out. It gets chunkier or more round for close vision. For a far focal point, the lens itself is stretched out and it becomes like a flatter situation. Okay, presbyopia. Those of you, and hopefully this hasn't happened to any of you yet, but you may have a parent or somebody who whenever they're reading something that normally you would read and you're just like, okay, they do this number. That's presbyopia. That's where the distance they have to accommodate has changed. And it just happens with age. So sometimes they'll get readers, little reader glasses that they can get for like $5 at Walmart, or they just hold it back so that that image can be refracted correctly in their eye. Constriction is when the pupils get smaller. Convergent means when they come together. So we had discussed that already. Here's parasympathetic, the difference here compared to the previous one. Look at these suspensory ligaments. They're not stretched out. They're relaxed. So this lens here is chunkier or more round. My pupil is smaller. Of course, my image is upside and reverse, upside down and reverse, inverted and reverse. But this is parasympathetic. You're reading, you're watching TV, unless it's like really far away. Okay, so just relaxing. You're also probably digesting at this point too, because that would be under parasympathetic activation. This is showing you the ciliary muscle. This is behind the iris. So right on top of here is the colored part of your eye. This muscle is a round muscle. So whenever it constricts or it dilates, it does for that whole pupil. It gives it its whole shape. And sphincter-like, and we don't really cover sphincters again until we get into, we did it in muscles, but sphincters until we get into digestion and reproduction. But sphincters are circular muscles, and so they kind of constrict or dilate to allow things in. In this case, we're allowing light in and out. Questions so far, or anything I can clarify? All right. Myopia is nearsightedness. Nearsightedness means that you can see better near than you can far. Farsightedness. Okay, so there you have that. Whenever you are nearsighted, it's because your eyeball is too long. If you're farsighted, it's because your eyeball is too short. So we give you a contact lens that helps lengthen or shorten the shape of your eye. That's what those contacts do. Okay? And it mentions that if you are nearsighted, we give you a concave lens. And if you're farsighted, we give you a convex lens. Okay, so astigmatism is where you have an unequal curvature. Your eyes are unequally curved in different parts of the cornea or the lens. So the cornea is the part on the outside, and the lens is the marble part on the inside. When you have astigmatism, there's different ways of correcting it, which is why you have to go to the doctor. If you're doing laser surgery, they're going to look at your lens first because that's more permanent. The cornea has epithelial tissue, so that's going to be replaced. We'll try to fix your lens first. That'll be more permanent. Yes, ma'am?
So how do they see things?
Who?
People with astigmatism.
It depends on where those curves are. And people with astigmatism,
Splitting their view?
and it doesn't split their, it's just that certain, like they've already accommodated to it, honestly. But they see different in one eye than they do another eye. And we're going to talk about the fact that you need both eyes to create a three-dimensional vision. So depending on
strain somewhere else to make it.
It
right.
just depends. And some people have a very mild form of astigmatism. Like they go to the eye doctor, the doctor's like, oh, you have astigmatism. And you're like, I had no idea. Like I feel like I can see perfect. And some people are like, I'm really struggling. Okay. And then the doctor's like, oh, well, you have astigmatism. So when someone says I have astigmatism, there's no defined, this is exactly what it is. It's very much a range of what that means. But ultimately, we either correct it by giving you a contact lens, or we can go in there in a laser surgery. they'll cut your cornea and they'll reshape your lens. They'll shave off part of your lens or your cornea, depending on what it is that needs to be corrected. Okay, so again, emmetropic means I have a normal eye. This is a normal, healthy eye. My focal point is my macula luda, my best vision, my fovea centralis there. This is exactly what I should see. Okay, if you are myopic or nearsighted, your eyeball's too long. So here's the focal point, but the focal point is way before it actually hits the macula luda. So we give you a contact lens to correct that, and here we give you the same thing, but this is for farsightedness. The eyeball's too short. Well, actually, this is still that same eye. Sorry. I was like, this is the lens that you use for that. So we give you a concave lens right here to change the shape and allow for that focal point to go back to your macula luda. Here is my short eyeball. I was like, that is the same eyeball. Sorry. I should probably read it before I teach it to you. Sorry. Hyperopic is where your eyeball is too short, so your focal point is actually behind your eye. So here, you see blurry. And we give you a biconvex lens, and it sits right there, and it makes that focal point show back up on your short eyeball. But when you take that contact lens out, then, of course, you can't see. Your focal point goes back to being the way that it is. Okay? Photoreceptor cells. Your rods and cones are replaced all the time. We have phagocytic cells or macrophages that stay in there and help clean up, because sometimes you look at something really bright and it damages those cones or those rods. So we don't want damaged tissue to be there. They're constantly being regenerated. Your vision doesn't normally, rods and cones don't normally tend to change with age, but what you can see, your focal point, the shape of your eyeball, all that can kind of change, but the rods and cones stay pretty consistent. Okay, so it mentions that intense light will cause damage. The fragments are phagocytized. Phagocytized just means that they're taken out like trash. So we get rid of all the trash that is there or present. We don't want it to be away. This slide reiterates what I had mentioned earlier about what rods do. Rods help you see shape, overall shape, but no specific details or color. Okay, it tells you the pathways when you're using rods, they converge, causing fuzzy, indistinct images. So you can't really tell what it is, you just know that something is there. Cones allow you to see color. Color blindness is lack of one or more cone pigments. So we have different pigments. There's 3 pigments, but we don't go into all of that for this part of anatomy. But you're missing one of those. And when we talk about cones, they only react when there's light. So you can only see color if there's light present. If there's no light present, you can't see color. Okay, so that, and there's no other explanation for that. If there's no light, you don't see color. Here it talks about the characteristics of rods versus the characteristics of cones. Now accommodation. Not accommodation, adaptation. When you're moving from being in dark to being in bright light. So you're asleep and your mom comes and turns on the light. And you get mad because it's painful. What's the first thing that you do? What does your face look like? Yes, you're like this. Why do your eyes do that? Why do you do that? It literally hurts. It's painful. You have nociceptors, pain receptors there that are telling you that light is painful. Because in the dark, what does your pupil look like? It's really, really big. And so you're just sleeping, relaxing, not waking up, and somebody turns on the light, and immediately, what do your pupils have to do? Get smaller. And that takes a little bit of time. Whenever you're doing that adaptation, that usually takes 5 to 10 minutes before you can actually see the way you're supposed to see. It just depends on your age and your pain tolerance level. Some of you can just keep your eyes open and be okay. Not me, I'm like this. I can't stand it. I find that it's very painful. But whenever light shows up, the rods, they're still working because rods are straight darkness. It's only rods, no cones. Cones are shut off. But as soon as you put light there, cones have to turn on so that you can see color. And rods are still functioning to help you see shape, but slowly starting because you're seeing color in specific details. Okay, so cones taking over. we're seeing a lot because of the bright light. Again, 5 to 10 minutes. The rod systems will slowly start to turn off. Your retinal sensitivity will decrease, so as you get used to it, your pupils get smaller, and then your cones are starting to allow you to see color. 5 to 10 minutes if you're going from dark to light. What about the reverse? If you're going from being in a really light situation, like you were outside and you walk into a dark house, that happens a lot during the summer. You cannot see anything. So it was super bright, you didn't have sunglasses on, and you walk into your house where you have all the windows closed, your air conditioner on because we live in Texas and it's super hot, and it takes you actually much longer to adapt from going from light to dark than it does from dark to light. Because in order to see dark, we have to turn off our cones and our rods have to turn on, and that adaptation time is much longer. It says there anywhere from 20 to 30 minutes before you can see the way that you're supposed to see.
There's no pain inflicted with that though.
There's not any pain. There is confusion. There's confusion because you're like, oh my gosh, like I know that my refrigerator's there, but I can't see it. And you're like, and you physically can't see it. And it's truly because you've just bleached, literally, the term is called bleach. We've just bleached them. And they're just like, okay, but we will, of course, we will adapt. So moving from bright to lightness, the cones have to stop, or from bright to darkness, not bright to lightness, sorry. Cones have to stop functioning. We have to get those rods turned on. Our pupils have to dilate to allow for more light to come in. But there's not nearly as much pain associated with that. There's just the confusion of why can't I see? And sometimes you're like blinking thinking it's going to increase the speed of the process, and it doesn't. Okay, night blindness. So what you were asking is due to rod degeneration. So this is your photoreceptors. This doesn't have anything to do with your lenses. Your photoreceptors. If this is happening early on and you notice that you're having trouble seeing at night, you can start taking vitamin A or eating vegetables that are high in vitamin A and increasing that, and it will slow or stop that process of degeneration. But if you've allowed it to occur for years, there's not anything you can do. You're just night blind. Okay? Retinitis pigmentosa. So we know that itis means what? Inflammation of. Right? So retinitis means it's an inflammation of the retina. Okay? And pigmentosa just tells us that the retina is the pigmented layer. There's a pigmented layer of the retina, so inflammation of that. That's an actual disease. And that disease can lead to night blindness, and vitamin A won't fix that. So if it's just a natural progression and perhaps you don't have a balanced diet, I know this is our first day together for some of you, but you should take a multivitamin every day. Multivitamin, shower, get some type of physical activity, okay, and drink water. 4 things, and you will live a really long time. Unless like something catastrophic happens or traumatic, like you get hit by a car. And I can't control that, but if you're just natural, like vitamin, multivitamin, it covers everything. Everything that you need to function. Water, you've taken a shower, and you're getting some physical activity. Walk to your mailbox every day. Okay, when we talked about the brain, and this is just a quick flashback, in 01 we talked about that there was lateralization of function, and then there was contralateral. Okay, here you can see that for each eye connects to both sides of the brain. Okay, so you can see that there's some crossing over, and the connection. This is just saying what part of the eyes are getting to our visual cortex, and our visual cortex is there in the back, and our occipital is posterior. And then once we see it, we associate it and try to figure out, have we seen this before? This area right here is called the optic chiasma. Chiasma just means across of that. We are not in the brain in O2. This depth perception, your depth perception is relying on you both eyes. If you were to one of your eyes, you know only 2 dimension. You see a third focus. You can't see the depth or the shape of both eyes are required to figure things. So when people play sports, if they it's very difficult for them to tell something is coming towards them. They could get hit in the baseball and they can't swing perceive the depth of that ball, how fast it's coming. Process depth of something. And cortex is whether or not you can cortex, and it allows you to actually process it. If you go before, then you recall it, like I can see that me to making a new memory. Cortical processing. I've seen it. I've seen talk to 01. Like you see a record. If I get somebody new that then I am trying to put their name with their face, and I'm trying to create a memory. So that's what we would do with the visual processing, the association cortex. And that's what this is discussing here. Okay, we are done with vision. Now we're going into the rest of our senses. So I told you vision was the biggest part, and then we get into the rest of it. So chemical senses. Smell is olfaction, taste is gustation. We use chemoreceptors to carry out both of these. Okay, so chemicals are used for both smell and taste. There is part we're going to do taste or smell first. Olfactory epithelium. Epithelial tells you that it's a type of tissue that's exposed to the environment. Olfaction tells you it has to do with smell. I'm sorry. All right. The way you smell things. Here is those nasal conch that we discussed when we looked at the anatomy of the nasal cavity, and here are these nerve endings, tree nerve endings that collect information from odorants, which are literally small little molecules that allow you to smell. They're chemicals. Once you smell it, that information is sent to this olfactory bulb, and this olfactory bulb, here's the brain right here, it takes it immediately to the brain. So sometimes, and we've discussed previously, sometimes you can smell something before you can see it. And sometimes you can see it before you can smell it. It just depends on what the stimulus is. When we talk about the way that you smell, it's the way that you're designed to smell is through your nose, not through your mouth. So you inhale, and then it goes through this turbulence where it's warmed and humidified. And these little conch here actually spin that air around so that it is warmed and humidified before it touches your lungs. So it would go from here down to your lungs. And the odorants are sticking here to the mucous membranes of that nasal epithelium so that you can smell. Here's a close-up look. So I'm going to go back real quick. Here, we're just going to take this part here. So we have my olfactory bulb and I have my free nerve endings. You can see here also, what bone is that? What's labeled here? Sorry, I was hoping that you would have to guess. But it's the ethmoid bone. It's the ethmoid bone, and we discussed that when we talked about the facial bones / cranial bones, all of them together. But we have these small little holes where these nerve endings are going straight up to my olfactory bulb. Again, I have bipolar cells here. Here, this is columnar, ciliated columnar epithelia. Okay, and then I have these free nerve endings here, and I can see that they're ciliated. There's a mucus here, so that it helps to catch things before it actually goes into my lungs. And then it sends that information on smell up to my brain to tell me, this is what you're smelling right now. We have sensitivity to a lot of different odors, but what we can actually smell is genetically predetermined. So you have genes, approximately 400, that's the textbook number, genes that allow you to smell things. It is very possible for me to smell something and you to smell something, and me to not like it and you to like it, or us to perceive it being different. That is definitely possible. We've gotten into a time where most things are, as far as genetics are concerned, like we can smell vanilla and know that we're smelling vanilla. Yeah. Okay. Okay, and some people can't smell that. It just depends on if that gene is turned on or off. Okay, so it mentions that. It does mention that those odors, so those odorants, little chemicals, have to bind to a receptor in order for us to smell them. So if they don't ever bind, we don't smell it. So like I said, sometimes I can smell it, or it smells one way to me, and it may smell different way to you, and that just might be a physical and anatomical difference between us. In your nose, you also have pain and temperature receptors. Pain receptors are called nociceptors, and that was the general sense, and temperature receptors are your thermoreceptors. So when you smell something that's really hot, or if you breathe in really warm air or cold air, that's painful. And we discussed, like, you run, if you're running and it's really, really cold, it's painful to you. And a lot of times, so you put something around that. Or if it's really, really hot, then that can also be painful. So you can smell that. You can smell pain. But smelling can be painful, yes.
But those genes aren't like inherited or anything like that.
Genes are inherited,
But
yes.
I mean, like the values of what you like and don't like in the smell.
Okay, on whether or not you like that or not. Let me just, so that I don't say the wrong answer. It depends. It's gonna be, it depends.
I just thought
A lot of times you don't like a smell because of something emotionally attached to that smell. And so that's gonna go into the limbic system, and your smells are associated with emotion. Your limbic system, when you smell something, if it makes you happy, it's because you've saved that happy memory. So you might not like it.
And now I just hate it.
Yeah. If you have a memory or something that created either you or when you smelled that, then you might like it. But your kid will inherit that same gene and maybe not have the same memory of that. Whether or not they like it or not. So like the intent is that you don't like it. And that once you smell it, it goes to the lobes. That's up here. And every is here in our class. That's what this is. And I think that has okay, never mind, go straight up. Through your system. Or like some people, everybody except one person had like, oh. Have the memory that you have to also smell your grandma's house. All those memories come in. Your taste is your smell. Like now, the taste is smell. We talk taste your sense. You have your tongue. Those bonds this is your taste bud. Here you are, just in this crevice, and every mix how to fall where you actually taste it. That's a 100% thing, because if you do it and you don't mix it with your saliva, you don't ever taste it. So in order for you to taste it, the bits of that food, the tasty parts of that food, have to mix with your saliva, and they have to fall into these crypts. So we're going to look at them just a little bit closer. And inside those crypts, so here's one of those purple things. I'm going to go back so you can see kind of what I'm looking at. There's a whole bunch of these, okay? And each one of them is attached to yellow, which is a nerve. Once it gets inside there, there are tiny little hairs, sensory hairs, that will take in that fluid, and then we have nerves here that will actually taste it. If it never gets to that point, then you don't taste it. If you taste something and it hurts your stomach, it elicits emotions, then you won't like it anymore. And if you taste something and you like it, it will elicit emotions and you like it, so it makes you happy, so you will eat it again. Okay? You hear a lot of people saying, oh, I'm allergic to that. And it's not that they're allergic to it, it's that for whatever reason, whenever they ate it, they threw up and it upset them, so they won't eat that again. But in order for you to taste something, it has to go down into this crypt, mixed up with your saliva, and it has to come into contact with one of these actual buds. So here are your physical taste buds. These are what we call papilla, the bumps on them. Okay, so there's a difference on that. Let me make sure I've covered everything here. Taste bud. There's microvilli, which are the hairs, and anytime it's microvilli, villi are for absorption. Cilia are for movement, villi are for absorption. So we're absorbing here. And your taste buds are replaced often. Usually weekly, they're replaced. You become less sensitive to taste with age. Hormones can affect whether or not you like the way something tastes. You might hate something right now, like spicy food. We tend to see people who can't tolerate spicy food younger. As they become older and less sensitive, they start to like spicy food. We see when women are pregnant and hormone levels fluctuate, that they like certain foods that they didn't normally like. And that sometimes has to do with cravings because of something they need, and it just might be that they just have this random taste that is caused by a surge in hormones. But the actual cells, the taste buds themselves, are replaced quite often. So if you burn your tongue, it's not a big deal. It's got epithelial tissue. It's going to replace itself. It'll blister and it'll be uncomfortable for a couple days, but you're going to be all right. You have 5 basic tastes. So we have sweet, sour, salty, bitter. Then there's umami. Umami is like the taste we have for broths, like a beef broth, a chicken broth. That's what that's referenced as. And when these notes were made, which was a few years ago, they were saying that in America we perhaps have a 6th taste, and it's a taste for fats. And they have established the fact that we now actually crave fats, which is why we like Whataburger French fries, and we crave stuff like that because we have a taste for it now that is separate from all of this. So you crave fatty foods, and that's the thing. So evidence that humans want fats, and we do, and so that's what that means. Whether you like or dislike something could have a homeostatic impact. Homeostasis is that internal balance, and we covered that over and over and over again. If you don't like something, it might be that it's going to cause you to become unhomeostatic, which means your stomach will hurt or your head will hurt or something like that. So that's a protective mechanism. If something causes you to throw up, it might not be that it's hurting you or it normally hurts you. It might be that just whatever you consumed at that point, whether it was something was going on in your body or something was going on with that food, it just didn't agree. So just because you don't like something the first time or it makes you sick the first time doesn't mean that it will other times. But it could definitely mean that it does. So it's one of those things. So we use our taste on whether or not something is going to be harmful or beneficial to us. So if we know that Whataburger French fries, eating them every single day is ultimately going to be harmful, does it stop us from eating them? No. Okay, so what I'm trying to say is, yeah, you can't just say, oh, well, if it was bad for me, I wouldn't want to eat it. What? Because you eat a lot of stuff that's not good for you. Okay, so just so that we're on the same page there. Physiology of taste. So we talked about the anatomy. The physiology is, in order for you to taste something, it has to be dissolved in your saliva. It has to make its way into that pore and come into contact with those hairs. If it does not do any of that, then you do not taste it. Okay, so when they're like, slow down and chew your food, so you can actually taste it. There's physiology to that. That's actually the function of that taste. Okay, and again, you can eat something so fast that you don't taste it. The roles of taste, as soon as you start to taste something, in fact, when you start to smell something or begin to even think of food, your body gets ready for you to eat. And especially if you're hungry and you start thinking of food, which is what causes your stomach to growl. Because when you were thinking of it, you were thinking of bacon and baked potato. Your body's like, that sounds really good. So immediately it starts to prepare itself to contact with processes. It's digested, and then guess you didn't eat that steak. You're not going to be here for a while. You're not going to eat it for a little bit. Your stomach is ready for you to take in. That's not to contract. And you're like, because you would eat. And once you start to think, starts to feel like if I say potato, trigger your stomach to get also might trigger taste it. You find it to throw up. Taste has okay, yes. Same with smell. So that this is what they see. So, and these are thermoreceptors, McKay. That's you paint red. There, that. Had anybody you can like don't even For their so when you turn well, and then this will actually is called because it's fancy. Here's your eardrum, also called the tympanic membrane, and the sound waves will vibrate this, which will cause these three bones to vibrate, which will then cause the fluid inside here to vibrate and you to hear. So we're gonna look at the anatomy first and the physiology. This part right here has nothing to do with whether or not you hear. This is your balance. So we call this the vestibular area. Well, this is technically the vestibule right here. These are your semicircular canals. You have 3 of them, and they tell you where your body is situated, whether you're, so all of that. And we're going to cover that when we get to physiology. You can see here that there's a nerve attached to each of this. So this is telling us where we're standing and our posture and so on, and this is telling us what we're hearing. We used to call this the auditory nerve, but we know now that it's not just hearing, it's also balance, so it changed its name to the vestibulocochlear nerve. So between the vestibule and the cochlea, it gives us information on balance and sound. So external ear, also called the auricle or pinna. So it's not called your earlobe. We call it our earlobe, but when you talk about it, we call it the auricle or pinna. The baby's born without their ear. The doctors don't say, oh, he's missing an ear, and they say he's lacking a pinna, or that's how it's referenced. It's not just said, when you talk to the parents, you're like, okay, they're missing the ear. But when they're talking amongst themselves with other smart people, they use those terms. So it's usually a pinna that is used. Okay? The helix is the outside part. The part that you call the earlobe is what we call the lobule area. The whole purpose of it is to funnel the sound waves into the external acoustic medius, which is what we used to call the auditory canal, which makes sense, auditory canal, because it's bringing in sound waves. But again, anatomy itself and all that is a language on its own. So making sure that you can understand it. We will use this structure that is intricately designed to get these sound waves all the way down to our eardrum. And our eardrum will then oscillate and cause those small little bones to vibrate and so on. The tympanic membrane is also called the eardrum. They're one and the same, so you should make sure you're familiar with both of them. The purpose is it serves the border between the external and the middle ear. Okay, and it vibrates. That's what it does physiologically, and it transfers sound waves into physical mechanical waves that we can comprehend and process. And I'll explain how that works when we get into the actual cochlea itself. The middle ear has this little, let me go back to the epitympanic recess, which is what I'm going to point out real quick. there it is. The epitympanic recess is this little area right here. It's in the middle ear, just so you have an idea what we're talking about, because I want to make those connections. So the purpose of that is when you hear things, it allows for like this acousticness to it, some vibration. It gives you some more richness in sound. But that's what that is. The pharyngeotympanic tube. Pharyngeo tells you what? It's pharyngeo. Your pharynx. That's right here. Where's tympanic? Yeah, it's your eardrum. We have a tube, the pharyngeotympanic tube, right here. Your ear actually drains into your pharynx and into your stomach. Yeah, you're welcome. You had no idea. Okay, and the taller you get, the more vertical it becomes, which it decreases the amount of times you'll have ear infections because that stuff doesn't sit there. And it drains the way it's supposed to. You never taste it. You can't be like, oh my gosh, that's so disgusting, because you've done it your whole life. You have no idea. But when we have little babies, we tend to see that their occurrence of ear infections is much higher than it is with adults, and it's because that tube is more horizontal. And so it doesn't drain the way it's supposed to. And so instead of going down, it gets stuck there, which is why we do a myringotomy, which is put tubes in your ears. And it talks about this in just a minute, but I want to use this picture. If this is too horizontal, so it can't really drain the way it's supposed to, all of that ruminant infection kind of stays up there. We put a hole here. And the way a myringotomy works by putting a tube in your ear, literally they take a scalpel or a small little probe, they kind of poke or cut right here, and they put like a little Lego. It's tiny, and if you've had tubes in your ears or had kids with tubes in your ears, you know it's like super tiny. And they sit it there, and it just puts a hole there so that instead of draining down in you like it's supposed to, it drains out. And if you've had tubes in your ears, or again, kids with them, you know that if they go to sleep on that ear, they may wake up and have a whole lot of drainage stuck to their face or pillow because it didn't go inside like it was supposed to. It came out, but at least it's not sitting there, allowing it to become infected. We notice that we know that as these kids begin to age, that ring just kind of pops out, and that tissue will heal because it can. It's a deal, and we have no issues later on in life. This was just a temporary thing until they were tall enough so that it could drain. So that's what tubes in your ears do. We call that procedure a myringotomy, which is, I can't call it. Or put
In the ear, does it affect it?
Well, okay. I will tell you this: that young child, their speech is connected here. So if their infections have been so chronic, and a lot of times we can see evidence. People or kids who have had infections also have teeth that's malformed, so they stain teeth. Not only for kids and their teeth, but they were all that medication. But had ear and that was backed up, could either have a delayed speech. So it's not like they talk baby talk. They've never heard sound before. So the way that they hear, just go ahead and get 6 to 8, and this kid's been on medication, so we just to alleviate the pain. There may be other.
Almost yell.
Never knew, then they don't know sense. I have quite a few, and I do they've never just but they know do okay. And so in here are the one moves two. Sarah, like different research. And this talk about the loudness on the decibel scale. So normally, if it doesn't cause pain, it's under 90 decibels. And if it causes pain or it's super loud or your ear's right up against it and it's more than 90 decibels, over time that can lead to conduction deafness, which is because those hairs get broken. And we'll talk about what hairs we're talking about. Not the hairs like if you have a hairy ear. We have other hairs. So here is showing you different sound waves. But this is what I want to get to. The transmission of sound because of the waves. Let me show you what this is. Here is this cochlea. They've rolled it out. So it was all rolled up like a snail. This is just for teaching purposes. It's been rolled out. When you hear something, the sound waves here hit the tympanic membrane and it uses these ossicles to turn it into a mechanical vibration. These mechanical waves will then cause the paralymph to vibrate. I can tell you how loud something is on how far this mechanical wave travels. If this mechanical wave stops right here, this is super loud and painful. That means I hear it right here. But if it is making contact back here, this is like somebody whispering. Like it's a very long wavelength and it's softer, so not a lot of damage. Okay? And whenever it makes contact, it disturbs that middle tube, the cochlear duct, the one that had the endolymph, and this is the one that's connected to the nerve. So when it hits here, it disturbs that, and that's where the nerve tells you this is what you hear. Okay? So in order for you to hear, the sound waves come in, the ossicles turn it into mechanical waves, and those mechanical waves will vibrate this paralymph, and where that paralymph distorts the cochlear duct, This has got endolymph in it. This is the part that's attached to the nerve. This is where it will be interpreted as this is what you hear. Okay? The closer that it hits, the louder. The further away, the more quiet. And remember that it doesn't look like this in your head. It's all rolled up really tightly. This is just used for teaching purposes. And it goes through the steps of hearing here. But I was just kind of showing you what was occurring. Again, here shows you if something is really loud, it's going to hit really close. Kind of here's the medium like us talking right now. And if somebody were whispering, it would hit further. And this is just for teaching purposes. Remember that this is all rolled up into a snail-shaped organ, which is called the cochlea. This is just unrolled so that you can see it. Questions on this? Okay? Right here is specifically talking about the hair cells that allow you to hear. So when they talk about those hairs have been broken and you can't hear anymore, it's because they're referencing this. So, this is the middle tube right here, the cochlear duct. And it has this membrane on it. Because here's the endolymph. Then here are these hairs. These are the hairs we're talking about. When this membrane moves, these hairs move. And when the hairs move, it tells the nerve, this is where that sound is. If these hairs become damaged, when this membrane moves, it never transmits the signal. Does that make sense? So it is not talking about the hairs that you see growing out of someone's ear. They're like, oh, they can't hear, because they damaged the hair in their ears. It's not that hair. It's hair that you can't see. And these are hairs that don't regenerate either. So once they've been broken, that damage is done. Okay? So these are the hair cells that actually transmit sound to the nerves and allow our brains to hear. Questions on sound? Okay, now orientation. So equilibrium or balance and how we're standing and where we're standing. So we use the semicircular canals for that. And this allows us to monitor our equilibrium. And we monitor equilibrium, we call it again equilibrium because it's talking about fluid. There's literally fluid in those canals that send a message to our brain to tell us where you're standing. Okay? And the macula, which, let me show you where I'm talking about right here. So here is my cochlea, saccule, semicircular canals, utricle. Those two purple things there are called the macula. Okay? These macula have tiny hairs as well. And when this membrane here moves, these hairs move. So like when you go forward, this membrane moves forward and it bends those hairs forward and it tells you you're moving forward and backward and right and left. The macula will send you that information. The spinning information is sent by the crista ampularis, which are here. That's rotational. But whether you're going forward or backward or side to side is sent by the macula. Again, hairs doing that. These hairs are less prone to damage. Okay, so this is not something that is normally, oh, you talk about the hair cells, now you can't balance yourself. Let me make sure I said horizontal, monitor the position of the head. Linear acceleration, but not rotation. Yes. Okay, the crista ampularis are the parts that allow for you to know if you're spinning or not. So the rotational movements are because of the crista ampularis. I don't know still how these people do it, and if any of you are dancers or ice skaters, props to you. But they call it spotting. I get the idea, but I've practiced myself and I fall every time. So I'm just glad that nobody else sees me practicing. And I just admitted that I practice spinning when nobody's around. Anyway, as you're spinning, if you're just a kid spinning and you don't know that you're supposed to be spotting or looking at a spot, what spotting is supposed to do is I look at it and then I spin and I find that spot, so I'm focused on it all of the time. And it keeps me from losing my balance. Even if I look at that spot, I lose my balance trying to look at that spot. So I'm sure there's a training class for that I should probably take. But ultimately what happens if you're a kid and you're spinning is that fluid starts spinning around. And then when you stop, that fluid doesn't stop because it's fluid. So how do you feel after you stop spinning? You're kind of like, oh. And once that fluid stops, that's when you know you've got your balance again. So that's for people who are not good at the whole spotting thing, like me. So that's talking about, and it's the crista ampullaris that sends that information to our brain to tell us that we're spinning. Vestibular nystagmus. This is where your eyes, so you're spinning, like to your right, and when you stop, your eyes immediately jerk to the left because you're trying to maintain balance, and that's what this is referencing here, is how your eyes go to the opposite direction while you're trying to maintain that balance. So as your rotation ends, your eyes continue, and that area in which you stop, they jerk back to the other, so it kind of causes you to do, this number, okay? Not that I need to reenact that, but, also vertigo. Vertigo is just you're being dizzy, okay? My papa used to say, I caught the vertigo. You can't really catch vertigo, like it's not a sickness. It's just that you're dizzy, okay? And that's because of that fluid there as well. Whenever we talk about how you know where your balance is a combination of your vestibular receptors, which are your semicircular canals, visual receptors, what your eyes see, and somatic receptors, what your muscles are telling you. So this is what's going to lead us into motion sickness. So knowing where we're at is a combination of things. It's not one thing dominating over the other.
So you can't mind over matters,
Ish. So that leads us to motion sickness. Motion sickness is when all three of those, like your muscles tell you you're not moving, but eyes tell you are, and your vestibular and they have them moving. So how do we so just kind of messages, so they things but the boat is going kind of up and down, and it makes them feel sick, so they have a 5-day cruise, and 3 of those days they're sick. So whenever somebody is suffering from motion sickness, they usually start sweating, salivating a whole lot, they turn that pallor color, or they're kind of really white, sometimes vomiting, nausea, all of that. We give them medicine to stop all of that. Hopefully that's the goal when you have motion sickness. Whenever you can't hear, 2 reasons you can't hear. Either there's something physically stopping you from hearing, so we call that conduction deafness, or your nerve has been damaged, so sensory neuro deafness. So if it's one or the other, that's how you determine how you're going to treat it. And if it's something physically stopping you from hearing, like you have an impacted earwax or something like that, we try to get that out. If there can be a surgery, we're going to try to do that. If it's nerve damage and it can be repaired, a lot of times we do implants right now, cochlear implants, and it will hear for you, so which is also why we have hearing aids. It just depends on what's causing you to be deaf, and then we take it on a patient-by-patient case and determine how to treat it. This tells you how we treat it. So it depends on how you're deaf, how we treat it. Tinnitus is where you just kind of have a ringing in your ears, like a constant ringing in your ears. This could tell you that you have some type of nerve damage. It could also be that you just heard something else. So sometimes if you fire a gun right next to your head, it kind of rings for a while and then it goes away. But if you have that constant ringing, that gives an indication that something may have been damaged nerve-wise. Meniere syndrome is where you it's a condition long-term because the fluids and stuff can't balance. You constantly feel dizzy, because you're dizzy, nauseated, go up. It's just the condition itself, Meniere syndrome. Developmental aspects. By the time you're born, all of your special senses should be functioning. You can't see you can see, but you can't see specific details, and you don't really know what you're seeing. We had discussed previously, that's why people get babies' faces, because they're really up close. And but they can hear, they can taste. Of course, they don't have a whole lot of distinction in taste because they've been in the uterus the whole time. But nonetheless, they start to develop all of those. They can hear in utero, recognize voices at birth. So recognize the mother's voice first, while she's pregnant. But it's not like from it's like perfect. From that, we early notice that you're you'll notice there's your eyes older, and there's presbyopia ones for that. And we'd also with eyes start dry out less and about functional or that. Newborns can their reflexes are completely reflex, not reflex. So if they hear a sound, they're going to look, and they're going to be. If you have the mother's voice, the baby, they're turned towards the baby because they're all sound, and it's not because they know it. It's just that it's the reflex. Had some death of that case as well. So you're late. You see number of hair and people you have you were in the 90s, but really that's all they are throughout life. Let's say